Hello everyone, welcome to another video. So in today's video we'll be talking about another sexually transmitted infection known as gonorrhea. So yesterday we treated syphilis, so today we're going to be treating gonorrhea. And basically gonorrhea is a common sexually transmitted infection, and it's caused by a specific type of bacteria, a gram-negative bacteria known as Neisseria gonorrhea. So this gonorrhea, it can affect both men and women, and it is known to affect the genital tract, the rectum, the throat, and the eyes. So if gonorrhea is left untreated, it can lead to serious reproductive complications, especially in women. So gonorrhea often presents with symptoms, but in many cases individuals may be asymptomatic, making it a silent transmitter. So gonorrhea is basically one of the oldest known sexually transmitted infections, historically referred to as the clap, and it continues to be a significant health concern due to the increasing antimicrobial resistance, which makes treating of this infection more challenging. So it affects mostly sexually active individuals of all ages, but it is most common among the adolescents and the young adults. So looking at the etiology, gonorrhea is caused by a bacterium known as Neisseria gonorrhea, and Neisseria gonorrhea is an organism that is gram-negative. It is a gram-negative diplococci that primarily infects the mucous membranes lined with columnar epithelium, such as the cervix, the urethra, the rectum, the pharynx, and the conjunctiva. So this Neisseria gonorrhea, it attaches to the mucosa using pili and other surface proteins, and it invades the tissues, causing inflammation and purulent discharge. So looking at the risk factors, so number one, having unprotected sexual intercourse, whether it's oral sex, anal or vaginal. So just having unprotected sexual intercourse in any of the forms is a major risk factor. Then having multiple sexual partners, if you are somebody that from one person you always go from one person to another, you are at risk of getting this gonorrhea. And then having previous sexual transmitted infections, like if you have had this history of other sexually transmitted infections, you are at risk of getting this gonorrhea. Then most sex workers and their clients are at risk, and then sexual partners of infected individuals are at risk of getting it too. And also lack of regular testing or access to healthcare services is also a risk factor. So looking at the anatomy and the physiology, so Neisseria gonorrhea, it primarily targets the mucous membrane of the urogenital tract, of the rectum, the pharynx, and the conjunctiva. So in females, the cervix is the most common site of infection, while in males it is the anterior urethra. So it causes localized inflammation and can ascend in females to involve the uterus and the fallopian tubes, potentially leading to something known as pelvic inflammatory disease. So in neonates, transmission can occur. Neonates are babies, so transmission can occur during childbirth, leading to something known as gonococcal ophthalmia. That is an eye infection that is caused by this gonorrhea. So for the pathophysiology, once this Neisseria gonorrhea enters the host, it uses the pili and the outer membrane proteins to adhere or attach to epithelial cells. It then invades and triggers an inflammatory immune response, recruiting neutrophils to the site of infection, resulting in purulent discharge. So in some cases, the bacteria can enter the bloodstream, leading to something known as disseminated gonococcal infection, which can affect the joints, causing gonococcal arthritis, the skin, and rarely, on rare occasions, the heart or the central nervous system. So how does this gonorrhea manifest itself? Like, what are the signs and symptoms if the individual has signs and symptoms? So for the clinical presentation, is different in men and women. So in men, there will be presence of painful urination, there will be purulent urethral discharge, which might be often yellow or green. Then there will be testicular pain or testicular swelling, and then there will be sorry, then there will be rectal pain, discharge, or bleeding in cases of when there's a rectal infection. So in women will often experience vaginal discharge, which is often thick or yellow green, and then painful urination, and then lower abdominal or pelvic pain will also be present. Then there will be pain during sexual intercourse, and then there will be intermenstrual bleeding, and then the rectal symptoms like rectal pain, rectal discharge if the rectum is involved. Then usually in women is when we have like they can be often asymptomatic in early stages of having this gonorrhea. So in neonates, that is the baby, there will be presence of eye redness, because in babies it shows in forms of gonococcal ophthalmia. So there will be eye redness, there will be swelling, there will be discharge. And then in cases of disseminated gonorrhea where it has entered the bloodstream, the presence of fever, joint pain, and skin lesions. So looking at the diagnosis, something called nucleic acid amplification test, and basically this is the gold standard for diagnosing gonorrhea. So this test, it detects the DNA of the bacteria in the urine or in the swabs from the urethra, from the cervix, from the throat, or the rectum. So it's the gold standard for diagnosing gonorrhea. Then we have gram staining. So gram staining shows gram-negative diplococci inside neutrophils, is especially useful in symptomatic men with urethral discharge, like the discharge that they get that is either that's either yellow or green. So it is useful in this case. Then we can also do the bacterial culture, which is needed to determine the antibiotic sensitivity, especially in cases of treatment failure or suspected resistance. So when we do this culture, we can know what antibiotics the organism is susceptible to and which ones is not susceptible to. So we can rule out the ones that are not needed and just give the ones that are very useful for the treatment. Then there's something called test of cure. So this way of diagnosing is recommended in cases of pharyngeal infection, or it's recommended in cases where there's gonorrhea with pregnancy. So looking at the other infections that could mirror the same symptoms as gonorrhea, so we have chlamydia trachomatis infection. So chlamydia too could mirror the same, we could see the same symptoms when the person has this infection of chlamydia. The urinary tract infection too, bacterial vaginosis, trichomoniasis, then herpes simplex virus infection, syphilis like we mentioned yesterday, pelvic inflammatory disease too. So for the management, the general principles when we're managing gonorrhea is that we have to treat both the patient and all the sexual partners. So we have to treat both the patients and all the their partners that they are currently in contact with, and then we emphasize the adherence to therapy and abstaining from sexual activity for at least 7 days after treatment. So we advise this, and we always consider co-infection with chlamydia trachomatis, because most of the time when the person has gonorrhea, it could co-infection with chlamydia could also occur. So dual therapy may be warranted. And then we also educate the patient on safe sex practices and routine screening. So for the pharmacological treatment that would give them, so due to the emerging resistance, treatment guidelines vary slightly by depending on region. This is why it's always good to get like this culture from the lab to know which is the best, to know which antibiotics that is more, the bacteria is more sensitive to. So as of the current recommendations, ceftriaxone injection single dose is the primary treatment, and 500 milligrams is administered intramuscularly once. Then if the chlamydia infection has not been ruled out, we can add doxycycline by mouth for 100 milligrams twice daily for 7 days. Then in pregnant women, ceftriaxone remains safe, but in pregnant women we have to avoid doxycycline and use azithromycin instead if the chlamydia coverage is needed. So in penicillin allergic patients or regions with confirmed resistance patterns, alternative agents may be used, but this susceptibility testing, like I said, is essential. So the ceftriaxone basically is a third generation cephalosporin, and it inhibits the bacterial cell wall synthesis by binding to the penicillin binding proteins, leading to cell lysis. So it's highly active against Neisseria gonorrhea, including many resistant strains. And when we are using the formulation, we can also use lidocaine as a diluent to reduce the pain if it's available in the hospital or if it's available in the pharmacy. So ceftriaxone is usually preferred because it generally has superior efficacy in treating pharyngeal gonorrhea, which is the form of gonorrhea that is harder to eradicate. And then the once daily single dose administration, it improves the compliance and is active against most resistant strains globally. Then since over 50% of people with gonorrhea are co-infected with chlamydia trachomatis, giving dual therapy is recommended unless it's ruled out by like a diagnostic testing, and in the testing it's shown that the person doesn't have chlamydia. So we can add doxycycline to the medication, and doxycycline is basically inhibits the protein synthesis by binding to the 30S ribosomal subunits, preventing the addition of amino acids to the polypeptide chains. So this is basically the mechanism of action of the doxycycline. But we try to avoid doxycycline in pregnancy, breastfeeding mothers, and children that are less than the age of 8 years. So alternative medications that can be used if ceftriaxone is not available, or if the patient is allergic, like he has a penicillin allergy. So these alternatives, they are less preferred due to the decreased efficacy and the higher resistance. So they are only used in cases where ceftriaxone is contraindicated and after susceptibility testing. So for example, we can use gentamicin plus azithromycin, and gentamicin is an aminoglycoside and azithromycin is a macrolide. So we use high dose of azithromycin to overcome the potential resistance. And then we can also use cefixime orally if the injectable therapy is not feasible. So you can use 400 milligrams orally as a single dose of cefixime. And cefixime is like an oral it's also a third generation cephalosporin, but is less effective against pharyngeal gonorrhea. So it must be combined with doxycycline if the chlamydia infection is not ruled out. So in treating with pregnancy, ceftriaxone is generally safe and it remains the first line. Doxycycline is contraindicated. Azithromycin should be used instead. Not azithromycin. So in pregnancy, doxycycline is contraindicated. So, and azithromycin should be used if chlamydia co-infection is suspected. So in terms of when the patient has complicated gonorrhea, so complicated gonorrhea is gonorrhea that is accompanied with some conditions, like for example, if the patient has pelvic inflammatory disease, so he has to do ceftriaxone plus doxycycline and add metronidazole if more anaerobic coverage is needed. Then in cases where the person has disseminated gonococcal infection, you can use ceftriaxone, continue for at least 7 days, then switch to oral cefixime when stable, and then add doxycycline. Then for gonococcal conjunctivitis, ceftriaxone is still the gold standard. Then we can irrigate the eye with saline. And then for neonatal ophthalmia, guys, gonococcal conjunctivitis in newborns, ceftriaxone. Then for prophylaxis, we could use erythromycin ophthalmic ointment at birth. So basically, if you see all these treatment guidelines, ceftriaxone still remains the gold standard. So ceftriaxone is basically the best to use in the cases of this gonorrhea. So with timely and appropriate treatment, gonorrhea is curable. However, when it's left untreated, that's when we start seeing complications like pelvic inflammatory disease in females, infertility in both sexes, disseminated gonococcal infection, increased risk of acquiring or transmitting HIV virus, and then neonatal blindness due to gonococcal conjunctivitis if it's passed from the mother to the baby during delivery. So reinfection of this gonorrhea is common if partners are not treated or if unsafe sexual practices they continue. So prevention is better than cure most of the time. So for someone to prevent themselves from getting this gonorrhea, it's best for them to continue with the constant and correct use of condoms, and then go for regular screening for sexually transmitted infections if you are known to have multiple partners. Then prompt treatment of their sexual partners, because most of the time people get sexually transmitted infections from their sexual partners if their sexual partners are not even trying to go for regular screening, or if they even have an infection, they don't even disclose it to their sexual partners. So prompt treatment of sexual partners is very useful. And then education on symptoms and risk of untreated gonorrhea, and also avoiding multiple or anonymous sexual partners, like having sexual partners that you don't even know about, you don't know their history, you don't even know where they are coming from, you don't even know if they are carrying something that could potentially harm you. And then when you are just every week there's a new person so all this can just contribute to having recurrent gonorrhea, having other sexually transmitted infections. So in this case, prevention is always better than cure, because curing an infection takes a lot, especially when it has gotten to the later stages of the infection, and especially if complications have started arising. So yeah, that is it about this topic. So I'll see you in the next video. Bye.